We had a very interesting session yesterday with lots of representatives from different countries around the world. Some of them are senior clinicians in those countries with an interest in chronic lymphocytic leukemia, and some of them were patient representatives. Some of the key messages that came out was that patients really feel across the globe that there's inequality of access to treatment and to diagnostics for CLL patients. We tried to unpick the reasons for that, some of the reasons for that, but mainly the session was about trying to identify possible solutions and what the next steps could be. Of course, patient advocacy is really key in this effort to try and get access to medicines across the world. The outlook of patients with CLL in high-income countries has very dramatically improved in the last 10 years or so with the introduction of targeted therapies. And recent studies now demonstrate that life expectancies of patients in high-income countries, for as long as they are treated within those high-income countries with the best available treatment, which is a big if, but if they are, then the life expectancy is almost equal to that of other age-matched and gender-matched people in the normal population. So, but that is obviously far from being true for patients in low-middle income countries, in particular in regions where only chemotherapy is available and where maybe CLL is not even diagnosed or underdiagnosed because there's a lack of awareness. So there's many ways to address this. As Eric and also the IWCLL together, we are trying to address this issue by through education. So we have online programs, we have preceptorships, we have visiting fellowships and training fellowships that both of the organizations are advertising for, and we are trying to encourage clinicians in the regions of the world to attend those educational events. On top of that, IWCLL works together with the Max Foundation on distributing patient by patient free zanubrutinib that is offered by Beijing as part of their efforts to expand reach for patients with CLL. And so we are kind of working with them as well on educating clinicians who are prescribing those freely available drugs to ensure that the right drug is given to the right patient at the right time. Which brings me to diagnostics, and it's a very important topic. I think one of the conclusions of this meeting was also that diagnostics is really essential, and that it starts with diagnosing hematological malignancies in general from blood tests more robustly. In many parts of the world, there's no availability of full blood count machines. So what that means is that clinicians rely on some other tests and sometimes only clinical examination to establish that patients have anemia. But then the conclusion usually is that they have vitamin deficiency or nutritional deficiencies, or they have worm infestation, and nobody thinks about leukemia. And it's really important that we raise that awareness, both in primary care but also in the general population, that when you receive blood transfusions, that does not necessarily mean that you have an anemia problem. It's actually quite often the case that it's a cancer problem. So. And then clearly, having more advanced diagnostics, including flow cytometry, is essential. And both Eric and IWCLL are already running programs across the world to ensure quality, high quality testing and results. So we then also very much thought about a more sustainable way of accessing drugs, whether it's through clinical studies and clinical trials, or through commercial supplies. And in many low middle income countries, there are people who can afford drugs, but there's also many people who cannot. And together with the pharmaceutical company and the regulators of those countries, we need to come up with solutions of how we can access and make drugs available at an affordable price. For HIV, this happened 20 years ago, GDP adapted pricing. The drugs are being produced in using the available patents in those countries locally, in many of those countries locally, which also reduces the cost. And generics need to be used and need to be encouraged to be used and need to be also tested for bioequivalence. So there's a lot of work that needs to happen in the next few years to ensure that pharma wants to come to those countries to run clinical studies and wants to sell those drugs in those countries, including also ensuring that pharmacovigilance is respected, so that when patients get side effects, in particular patients of other ethnic groups, that there is a mechanism to highlight those side effects to pharma industry. And so at the moment, the situation is quite dramatic in that you see counterfeit drugs, generics, sometimes even the original drugs entering those markets in a completely unregulated way. And of course, these populations, unfortunately, whether they're of African descent, of Indian descent, of Chinese descent, they have not been represented in the clinical trials that are dominated by Caucasians. And we don't know what the potential side effects are when we are giving those drugs. Now, I'm not saying that we should not give those drugs because those patients have leukemia. So at the end of the day, it's a very fine line of how to approach this issue. But we have to do a lot more work on pharmacovigilance.